Hello and welcome to our TIF Talk this evening. We're very excited to have our special guest who's been here before, Dr. Gilbert Simoni. Thank you for being here tonight and welcome.
Thank you. Thank you so much.
Yeah, no problem. So a little bit of background on Dr. Simoni. He is an interventional gastroenterologist and natural orifice surgeon who is board certified in both internal medicine and gastroenterology. He founded Advanced GI Incorporated in 2006 with the mission of building patient trust and being the catalyst for a healthier lifestyle through prevention, early detection, and an innovative approach to GI care. Dr. Simoni and his care team are known for their friendly and gentle bedside manner, communication, and responsiveness. Dr. Simoni's special areas of interest include minimally invasive surgical treatment for GERD, wireless capsule endoscopy, wireless pH monitoring, and impedance pH, inflammatory bowel disease, and other endoscopic interventions. So welcome, Dr. Simoni, again, and thank you for being here with us this evening.
Thank you, Andrea, and I wanted to thank Endogastric Solutions for making this possible, and those who have joined in on social media. I appreciate you being here and spending some time with us. And thank you for that wonderful introduction, Andrea.
Yeah. So just a couple of housekeeping items before we start, Dr. Simoni. If you are tuning in tonight, please feel free to ask any questions for Dr. Simoni, and you can type them in the comment section. And if you comment where you are tuning in from, you could potentially win a TIF tumbler that we are giving away tonight. So a comment where you are tuning in from. And then the other thing is, we'll talk about that a little bit later. We have a little surprise for you that Dr. Simoni is going to go over. But so we can go ahead and get started, Dr. Simoni. Let's talk. We're here obviously to talk about GERD and the TIF procedure. So you can kind of give us an explanation of what is GERD and discuss the TIF procedure as well.
Absolutely. Thank you. Thanks again for the opportunity. A lot of times we get questions as to what is really GERD. One of the things that I have to really explain to everyone is that in medicine we not use acronyms, but it just makes things a little bit easier to talk about and discuss. So GERD stands for gastroesophageal reflux disease, and it is not the same as just heartburn. We're going to talk about that in a moment. So what is GERD? It's a disease that afflicts millions of people across the world, and it is a condition that truly needs to be paid attention to, and we're going to talk about as to why that is so. So gastroesophageal reflux disease is a condition that has to do with a valve, a mechanical failure of a valve. You can think of it as a one-way valve that sits between your esophagus and your stomach. As you can see in this slide, patients who do not have a valve that works properly, or what we call a competent valve, the contents of the stomach constantly come up into the esophagus. This upsplashing or coming up of the contents of the stomach is called GERD. Despite a lot of misconceptions, GERD is not just because of increased production of acid or somebody having too much acid in their stomach. The stomach is designed to have acid in it, and you're supposed to have acid in your stomach. It's just that it should not be coming up into your esophagus. Now, as I mentioned earlier, GERD is not just heartburn, and there are lots of different symptoms. As we can go to the next slide, we'll show you that there are a lot of different symptoms that GERD can present with, and it's not just heartburn. In my profession, we usually like to categorize these symptoms into two major categories: the typical symptoms of GERD and atypical symptoms of GERD. And to be honest with you, most of the patients that come to see me, they come in because of the atypical symptoms. So what are typical symptoms? As you can see listed there, typical symptoms are symptoms that everybody knows is related to reflux: heartburn, chest burning sensation, excessive salivation, regurgitation, and sensitivity to some foods. These are things that almost everybody knows it has to do with reflux. But on the opposite side, atypical GERD are patients who have been suffering from things that are not readily known as being related to reflux, such as chronic cough, chronic sinusitis, adult onset asthma. There are patients who may have dental erosions, and also patients who may have difficulty swallowing, hoarseness of the voice, or clearing of the voice all the time. So a lot of times, unfortunately, patients who suffer from atypical symptoms, they tend to see quite a number of physicians until someone finds out that they actually had GERD, and they get to see us as gastroenterologists or GI doctors. So, all of these symptoms are essentially related to this non-working or incompetent valve, if you will, which we call lower esophageal sphincter. I hope that that gives some insight into what GERD really is.
Yeah, beautiful. Thank you. You've got a lot of fans out there. We've got a lot of questions that have already come up. So let's go ahead and get a couple questions through, and then we'll continue talking about everything. So everyone's saying hi, so that's great. So hello, everyone.
Hi,
Thank
everyone.
you. So a question here is from Jill. Do you do hiatal hernia repair in conjunction with the TIF procedure?
I'm a gastroenterologist, so I don't personally do the hiatal hernia repair, especially if it's a larger than 2 centimeter hiatal hernia. So I have surgical colleagues who have been working with me for the past decade or so, doing these procedures. So if someone has a small hiatal hernia, less than 2 centimeter hiatal hernia, yes, I do the TIF procedure. It actually reduces that hiatal hernia. Larger than 2 centimeter hiatal hernias, I have colleagues that do laparoscopic hiatal hernia repair in conjunction with TIF. We call it concomitant TIF or CTIF.
Wonderful. Thank you.
Thank you.
Another question, can gastric reflux cause increased sinus flare-ups post-nasal drip?
Excellent question. Absolutely. Those sinus issues and post-nasal drip are part of the atypical symptoms of gastroesophageal reflux disease. In some patients, GERD might not be the only reason for that, but it certainly can exacerbate some of those symptoms. For instance, if someone has hay fever or they have allergies, and on top of that, they have gastroesophageal reflux disease, their symptoms are significantly multiplied and exacerbated. So yes, absolutely. And a lot of those patients who, as we go through my presentation, we'll talk about how we figure out patients, whether they have GERD and if they need a TIF procedure. Once we figure out and they have had the TIF and we get rid of the gastroesophageal reflux disease, their symptoms become much less frequent, and at some point they actually may go away. Excellent question. Thank you.
Yeah. So why don't we just go into it right now and talk about your diagnostic workup for determining whether or not a patient is a candidate for the TIF procedure.
Absolutely. If you don't mind, I'm going to give a little bit of understanding as to how we or how in the community GERD is managed. The gastroesophageal reflux disease is a lot of times treated by medications. The patient goes in to see a physician, they give them some pills and say, okay, take this forever, and that should take care of your symptoms. Yes, the pills do take care of symptoms, but they do not get rid of the actual underlying problem. They just mask the symptoms. And why is it important for us to actually talk about gastroesophageal reflux disease? There's a slide that I have here if you want to show that. So a lot of patients, especially the last person that asked about sinus issues, a lot of patients have what we call silent GERD, meaning that they really don't have heartburn or they have atypical symptoms. So those patients can go on for years without being evaluated properly, and they can develop esophagitis, which is inflammation of the esophagus. If that continues to go on despite taking medications, it can lead to Barrett's esophagus, which is a precancerous change, and Barrett's can go to esophageal cancer. So potentially reflux can lead to esophageal cancer. That is a very important information that patients and their physicians should really be considering. Now, as far as some of the management goes, we talk about food and lifestyle changes. We tell patients to avoid certain things like chocolate and soda, peppermints, fried foods, wine. And most patients who are GERD probably already know about all of this. The unfortunate fact is that a lot of these lifestyle changes and avoidance of foods doesn't, again, take care of the root cause of GERD, and they just basically provide symptom relief, if any, and they are really not effective for a long period of time. That brings us to the question you just posed. So how do we take care of the GERD, and how do we evaluate patients to offer them the TIF procedure or anti-reflux procedure? Little bit of background. TIF stands for transoral, which means through the mouth, incisionless, which is without cutting, fundoplication, which is essentially taking the stomach and wrapping it around to create a normal or competent valve. As you can see in this slide, in the top left corner, that's our device that we use. It's called the esophagus. We go into the stomach under direct visualization. We take the portions of the valve that are loose, and we essentially create a pleat and wrap it, and we recreate a normal valve that's supposed to be there. So we basically reshape the valve into its original form that it's supposed to be. So TIF is based on an old, which is still being used, surgical intervention called Nissan fundoplication. Nissan fundoplication, which it has been a lengthy procedure. It used to be about 3-hour procedure. It has gotten less time-consuming, if you will, in the operating room, but still pretty invasive, where they take the stomach and they essentially wrap it around the esophagus to recreate the valve. But Nissan, unfortunately, has a lot of post-op side effects. A lot of patients have increased gas and bloating. They can't vomit. They can't belch. And there's a high chance of recurrence within a 10-year period after Nissan fundoplication. With TIF, on the other hand, it's non-invasive. As I said, it's through the mouth and without incisions. In majority of the cases, it's outpatient. The actual TIF takes about 20 minutes, and patients, it's done as an outpatient. So you have the procedure in the morning, and you can be home by noon.
Perfect. Thank you.
Thank you.
So let's answer a couple more questions since they're coming in. Tara's asking, how many TIF procedures have you done, Dr. Simoni?
More than I can count. Honestly, hundreds. I started TIF in 2009, and I average about 4 or 5 TIFs per month. So you do the math.
Yeah, fantastic. Another question from Mike. Do you only have GERD at a certain age?
And not necessarily. Although as we get older, a lot of things happen, and one of them being, especially in this country, there's a significant problem with being overweight and having obesity. As we get older, that happens. Also, things get looser. Certain things throughout life, especially pregnancy, can put pressure on the diaphragm. But there are patients who are born with certain defects, and they may have a loose hiatal hernia or I should say a defective hiatus, which is essentially a natural defect within the diaphragm muscle. And that could give rise to patients having gastroesophageal reflux disease at an very early age. So it doesn't necessarily have to be later in life for you to have gastroesophageal reflux disease.
And they talk about babies even having
Absolutely.
GERD, right? As young as that age. Yeah. So, okay, another question from Linda. She's asking, and I think you mentioned this already earlier when we talked about kind of atypical symptoms, but she's asking, do you get a cough, clearing your throat, sometimes lose your voice? Because she's been diagnosed with GERD. So she's asking, is that normal to have those types of symptoms? Which I'll let you answer.
Well, those symptoms are not normal, but they're extremely common in patients with gastroesophageal reflux disease. As a matter of fact, as I said earlier on, majority of my patients who come in and seek help is because they do have those atypical symptoms, such as hoarseness of the voice or clearing of their throat all the time and having phlegm in their throat or postnasal drip. And the problem with those symptoms is that those are not always acid related. So the reason typical symptoms are more related to acid is because the acid actually causes the burning sensation. Majority of the patients who have sinus issues or voice issues, it's not necessarily the acid, it's the fumes of the refluxate, if you will, or the contents of the stomach, and it could just be bile, could be any of the contents of the stomach that could potentially cause irritation of the back of the throat and sinuses.
Okay, thank you.
Sure.
We've got a question here in regards to PPIs, and then maybe we can go into a little bit about, the long-term, are there long-term side effects of PPI use? But the question that someone's asking, can I stop taking my PPIs after TIF? So maybe you can answer that and then talk a little bit about why maybe patients are feeling like I want to get off my PPIs because they heard about long-term side effects.
Yes, the whole premise of doing the TIF procedure is to get patients off of the PPIs or proton pump inhibitors. Just to give you an idea of what PPIs are for those of you who don't know what PPIs are. As I said, unfortunately in medicine we use a lot of acronyms. So PPIs stand for proton pump inhibitors. Proton pumps are these factories or cells in your stomach that actually produce acid. So PPIs just shut those factories down so you don't produce any acid. As you might imagine, if you don't have acid in the stomach, there are a lot of different processes that are supposed to occur naturally because of the acid in the stomach. And you take that away, there are problems that can occur. And over the years, we have learned that chronic use of PPIs or proton pump inhibitors can cause several complications, such as osteoporosis. That's one of the major ones that we've seen. Patients who use PPIs for a long period of time, they may develop anemia, especially iron deficiency anemia. They may have lack of certain minerals, magnesium, calcium. And also it can put patients at risk of different infections, such as Clostridium difficile or C. diff infection, that the risk of developing that goes much higher when you're on PPIs. Also, a recent study had shown that taking double dose of proton pump inhibitors on a daily basis also increased chance of contracting COVID. So there are a lot of different issues with the proton pumpers. And as a matter of fact, I have a slide in here that kind of gives you all the published risk factors that have been associated with proton pump inhibitor use, and it's quite an extensive slide. I'm not going to go through each and every one of them, but as you can see on the right side, there's a list of all the scientific studies that have shown the problems with PPI use over a long period of time. So, again, a short answer. It's not great to take PPIs for a long period of time, and once you have the TIF, yes, the whole point of doing it is to get you off of these medications.
Fantastic. We'll ask another question, and then we'll talk a little bit more. There's a ton of questions here, so
love questions.
Yeah, they love asking you questions. Okay, so Allison's asking, my gastro told me that with the Nissan, the people who have the best results are well controlled on PPIs and have typical symptoms. Do you find that this is the case with TIF?
Not necessarily, no. With TIF, I have been very successful in treating patients who have both typical and atypical symptoms. As a matter of fact, some of the studies for TIF have shown that people who've had difficulty swallowing due to some other issues, they actually got better after doing the TIF procedure, which is the opposite of what you see with Nissan fundoplication. Most patients who've had a Nissan fundoplication will tell you that difficulty swallowing is actually one of the major side effects that lasts a long time. So you don't always have to be responsive to proton pump inhibitors. And the reason for that is that, as I said earlier, not a lot of patients' reflux or GERD is related to acid. It could be related to bile or some other contents of the stomach that comes up. So just responding to PPIs is a good indicator that you will do well with surgery, but not responding to it doesn't necessarily rule out that you're going to do well with TIF. Yeah, at least in my experience.
Yeah, perfect. I saw when you were looking at the slides, a slide of the Nissan, and we get questions all the time in regards to what is the difference between Nissan and the TIF procedure. And maybe, I'm not sure what you were going to say about that slide, but maybe you can talk a little bit about that.
Sure, absolutely. So we can go back to that slide, actually, if you can. That way I can kind of walk through it. So there are many different differences between Nissan fundoplication and TIF procedure. So as you can see on the top right image, the entire top of the stomach is grabbed and it's wrapped around the esophagus and sutured into the esophagus. In order for this to happen, the surgeons, what they do is they deflate the stomach. Deflating the stomach makes the status of the stomach in a very unnatural, makes it an unnatural position. So what happens is that the surgeon takes out all the air from the stomach, and then they loosen up the top of the stomach, and they basically grab it and wrap it around and suture to the esophagus. One of the problems with that is that you're not really creating a new valve. All you're doing is just essentially putting a noose around the esophagus by taking the gastric folds, if you will, or the lining of the stomach and wrapping it around itself. Nissan is also a 360-degree wrap, which is at times it's too tight and sometimes it's too loose. And the reason for that technically is because of that deflation of the stomach. In a normal status of the stomach, you have air and fluids and food and gas and all kinds of stuff in your stomach. So your stomach is actually distended. When we do a TIF procedure, we distend the stomach at its maximum distension, and then we wrap the esophagus. And we don't do a 360-degree wrap. We do a 270 to about 300 degrees. This essentially avoids certain complications that can happen with Nissan, such as putting sutures through the vagus nerve. The vagus nerve is a major nerve that actually runs behind the esophagus and controls how your stomach empties out, and also can affect the rest of the digestive tract. So when you have a potentially, not all Nissan surgeons do that, but in certain cases it would be difficult not to affect the vagus nerve, especially if you're doing a 360-degree wrap. The other issue with the Nissan fundoplication is that in order for you to really free up the top of the stomach, you have to cut away nerves and veins and arteries that supply that area of the stomach in order to be able to wrap it around. We don't do that during the TIF procedure. Even when we do a hiatal hernia or concomitant TIF, the surgeons only clean up the area where the hernia is, and they just suture the diaphragm, and they do not take down any of the nerves or arteries or veins that are associated with the stomach. So based on those major differences, TIF is significantly similar to what a normal valve is supposed to be. I hope that answers the questions.
It sure did. Thank you very much.
Sure.
So let's get, she's asking actually another question, Allison. Is it safe to get pregnant after having TIF, or would pregnancy harm the surgical site?
You can get pregnant after TIF, and there's should be absolutely no problems whatsoever. Now, pregnancy, as I said earlier, can at times put pressure on the stomach and cause recreation of the hiatal hernia or recreating the valve. If everything else is constant, if someone doesn't gain significant amount of weight pre-pregnancy, and they essentially lead a moderate life with moderation of foods and making sure that they exercise and keep fit, pregnancy should not really affect it. I've had many patients who've had the TIF procedure and they were pregnant afterwards, and there's been no complications or any issues.
Perfect. Wonderful. So just a reminder, if you're just tuning in or just recently tuned in, please feel free to comment where you're tuning in from. We're giving away a TIF tumbler tonight, so you could be one of the winners. And then let's talk a little bit about recovery. I know you have a special slide that's gonna, answer all the questions that these patients are always asking about, and it's always the diet. But talk to us a little bit about recovery and what can patients expect kind of post-operation?
Absolutely. So post-op TIF, just to give you an overview, majority of the patients, the only symptoms they have after TIF is a little bit of chest discomfort, some sore throat that lasts a few days and then goes away. Those that also have a hiatal hernia repair, they oftentimes get shoulder pain, and that's because the surgeons suture the diaphragm, and there's a nerve called the phrenic nerve that traverses and innervates the diaphragm, and when you put sutures in it, obviously that causes shoulder pain. Aside from that, most patients don't have a lot of side effects post TIF. However, a lot of patients know that, especially in my practice, I have a 6-week diet, and despite a lot of feelings that, oh my God, I'm going to be on a liquid diet for 6 weeks. That's absolutely not true. That's why I would love to put the slide up and show patients what we usually do after the TIF procedure. So as far as activity goes, I recommend patients not to lift anything heavy, nothing heavier than 5 pounds for about 3 weeks, and nothing heavier than 15 pounds for about 6 weeks. And then we have a gradual diet. So on first week, we recommend patients to stay on liquids. On on week 2, we bump it up a little bit. We recommend patients to start having yogurt, cottage cheese, broth. They can have strained soups, nutritional supplements, well-cooked and pureed vegetables, pudding, and so on. And as you go on, I think we can probably send everybody a link to this diet. But as you go on, you get more and more dietary ingredients into your daily food as weeks go on, to the point that by week 5 and 6, you're going to be eating essentially normal. You're going to be on bread, and you can have your coffee, wine, steak. So it's not a horrible diet. It's just the first week might be a little bit difficult to be on liquids, and after that it gets easier and easier. Most patients that we talk to after having this surgical procedure, the TIF procedure, they realize that actually that diet does a couple of things. One, it helps them lose some weight, which does help with reducing the pressure, the intra-abdominal pressure on the stomach, and also gives them an idea of how to moderate their diet and how to stay away from certain things. But once they're done, they realize that, oh my God, there are things that I couldn't eat for. I had a patient who hadn't had tri-tip, for instance, for about 20 years. And, after TIF, that's unfortunately all he had. But I'm not saying that that's what they should do. But after the TIF, once you go through the diet and you follow the instructions, you'll be offered the proton pump inhibitors and lead a pretty normal life. And patients are extremely happy after having had the TIF procedure.
Fantastic. We got a lot of people asking for that diet. So if you're watching and you would love Dr. Simoni's proprietary diet, post-TIF diet, please just comment diet or diet, please, or let us know, and we'll send you a link to his diet. It goes directly to his website, and there's a link for that, all of that information. So thank you, Dr. Simoni.
My pleasure.
A lot of people excited about that. Okay, a couple more questions that have come up. Sorry, I'm scrolling through them, making sure I don't miss anything. This is an interesting one, especially during this time. So it says, during this time of COVID, is it safe for me to come to your office and then proceed to get the TIF procedure at the hospital?
Absolutely, yes. I am proud to say that since the epidemic actually started, we have done significant number of changes to how we do business in my office. First of all, we don't, at any particular point, we do not have more than 10 people in our office. We have all the precautions to have social distancing. We have barriers, PPE, protective, personal protective equipment, PPEs. Masks. I mean, all the stuff that has been recommended. We follow those, and I'm proud to say that we have had absolutely no cases of COVID that has been associated with any office visit, and all of my staff are vaccinated, and also the cases of COVID in our area have dropped significantly. The hospital has made significant changes in making the environment safer. However, to give some extra assurance to patients. Majority of the pre-op evaluation, I actually do them right in my office. You don't have to go to the hospital or to any surgical center. However, the surgical centers that we do the TIF procedure have also had significant changes to make sure that they're compliant with COVID, and they've had absolutely no complications, to my knowledge, for any particular procedures. There is a surgical hospital and outpatient surgery center that I do the TIF procedures in as well as doing some of the hiatal hernia repairs with my colleagues. And every patient gets pre-op COVID test beforehand, and all the staff are extremely careful, and there's been significant sanitization of all the surfaces and the rooms, and it's basically significant changes. Not that we didn't do any of these precautions before, but we are doing extra precautions on top of things that we normally do for patients anyways in our surgical centers.
Yeah, probably much more safer than even just going to the grocery store, right?
Absolutely. It's significantly much safer to go to the grocery store than going to the grocery store.
Right. Absolutely. Okay, so a couple more questions. Where are you located, and are you taking, that's a good one. Pamela's asking, where are you located, and are you taking new patients?
Absolutely, we are taking new patients all the time. We do take new patients. I do recommend for new patients to come into the office if possible. All this follow-up visits or things that don't actually require for the patients to come in, we do televisits for. I'm located in Thousand Oaks, California, and I get patients that come from as far north as Alaska and as far south as Australia. So,
wow.
Yeah.
Everywhere. All right. Well, you can go see Dr. Simoni. We do have Debbie who's asking, who is the best candidate for the TIF procedure? I know you talked a little bit about this, but maybe just jumping on, but you maybe can answer that question.
Absolutely. To be honest with you, anyone who has gastroesophageal reflux disease. Now, there are some caveats. There are certain things that we really have to make sure that we evaluate. Number one, patient who has gastroesophageal reflux disease, we want to make sure that there are no other conditions that could mimic reflux, especially if patients have gas and bloating or abdominal pain, which I put them under an umbrella of dyspepsia. Sometimes gallbladder issues could mimic reflux symptoms, so we want to make sure we're not dealing with that. Also, we evaluate patients' esophagus. In order for you to have any kind of anti-reflux surgery, you must have an esophagus that whose motility is intact. That means you do not have, excuse the term, but it's we call it, for layman terms, we call it lazy esophagus. So patients who have a lazy esophagus, they may not be candidates for TIF, or they may need a special evaluation at one of the tertiary care centers in order to make sure that they can have the TIF procedure, that they can withstand with swallowing of the food. Other patients who are supposed to be candidates are, you have to be above age of 18. I don't see any patients who are pediatric age. And there are some few things, few conditions, such as achalasia, or patients who've got Sjogren's disease, and some of the autoimmune issues that affect the motility of the esophagus. Patients may not be a candidate for TIF.
Perfect. Thank you. Another question, do they always do a scope for GERD?
Absolutely. One of the, since I've been doing TIF for more than a decade, I've talked to a lot of other physicians, and I've trained a lot of physicians who have done this. And there is a small subset of patients that, or subset of patients who've had TIF, but they didn't do very well. When I go back and look at some of the some of those cases, and I discuss it with the physicians who are on in their career doing a TIF procedure, what I've seen is that if a patient has seen a gastroenterologist who's not familiar with TIF or familiar with doing a gastroesophageal reflux surgical treatment, they may not really pay a lot of attention to the lower esophageal sphincter and its shape. I have seen a lot of patients who have seen another gastroenterologist, and they had an endoscopy, and they were told, "Oh, you don't have a hiatal hernia." And I go in and I do an endoscopy, and we find a huge hiatal hernia of 5 or 6 centimeters. So when I do train other surgeons and GIs in doing a TIF procedure, I always recommend to do your own endoscopy because you don't want to go into the operating room and you want to do a regular TIF or TIF without a hiatal hernia surgery, and all of a sudden you see this big, huge hernia. So you have to cancel the surgery and go out and reschedule the patients for a hiatal hernia or CTIF or concomitant TIF procedure. So to avoid that, the best thing to do is for the person who is going to be doing the TIF should do an endoscopy on you and find out exactly what's going on, because they're the ones that are going to be doing the surgery, and they should have a very good evaluation and idea as to what kind of esophageal sphincter you have, how big of a hernia you have, because the size of the hernia will make a huge difference as to how we're going to treat you.
Yeah, that's a good point. That's a good point. There is a question that just came up asking if they have any, do we have any doctors in Texas? So for any of you that are not in the area or don't want to fly to California, we do have a website called gerdhelp.com. And if you go there, you can put in your zip code or your state, and you'll be able to find a TIF trained physician in your area. And we do have a lot. I actually live in Austin, Texas. So I do know we do have quite a few well-trained physicians in Texas as well. So a couple more questions before we end. We're getting close to the top of the hour. But we have a question here about gastroparesis. Can gastroparesis affect or cause GERD?
Absolutely, yes. Gastroparesis means, for those that don't know the term, gastroparesis means a lazy stomach or a paralyzed stomach, if you will. Yes, if your stomach is not emptying properly, then the contents of the stomach can accumulate and can cause reflux. Even if you do not have a hiatal hernia or you do not have a loose valve. And it can affect the outcome of the TIF procedure if it's not addressed beforehand. A lot of patients who have gastroparesis, they have gas and bloating or nausea that gets worse as the day progresses. If you don't address that and you do a TIF procedure, then those symptoms might get exacerbated. Your reflux will go away, but your symptoms of gas and bloating might get increased. Now, one of the first things that I would like to do when someone has gastroparesis is to find out why and treat the underlying issue, and hopefully the gastroparesis goes away. For those who have what we call idiopathic gastroparesis, where we can't find out why they have gastroparesis, we sometimes with my surgeons, we provide treatments for the gastroparesis beforehand. We either inject Botox in the outlet of the stomach. Excuse me. Or we do a surgical procedure called pyloroplasty, where the surgeon opens up the valve that leads to the small intestine from the stomach. And in rare cases, we have had patients who've had pacemaker for their gastroparesis. Yes, gastroparesis can affect all of those, but the best thing to do is to treat that or address it before we do the TIF procedure, at least in my practice.
Fantastic. Thank you, Dr. Simoni.
Right.
Well, I believe that's all of the questions that we've got. Let's see.
Excellent.
Oh, one last question. One last question before we conclude the evening. Linda's asking, would I need to go back to the doctor and check, have a doctor check me for TIF? I've had hernia repairs. Would the hernia repairs I think she's saying, could the hernia repairs have caused the GERD? So I guess she's asking if she should go back and potentially get re-seen if she's still having issues, probably.
Absolutely, yeah. If someone there's very little data about patients who have GERD and just have a hiatal hernia repair. I always tell my patients, having a loose valve and a hiatal hernia is almost like having a big washer and a screw that doesn't really fit each other. So just fixing the washer or fixing the hiatal hernia doesn't necessarily get rid of the symptoms. So if you're talking about having had just a hiatal hernia surgery and now you're having recurrence of symptoms, that's because you also need to fix the valve. So that's why we usually do concomitant hiatal hernia with TIF. And majority of the time when patients just have a hiatal hernia repair and they leave the lower esophageal sphincter alone, then obviously you're going to end up having reflux again, if I understand that correctly.
Yeah.
So yes, I would definitely go back to the person who fix a hiatal hernia and talk to them about the TIF procedure, or find someone who is familiar with the TIF and discuss your issue with them.
Perfect. Thank you.
Sure.
Well, we've concluded all the questions that have come up. But before we end tonight, I wanted to give you an opportunity to let all of our viewers, hear any last words of advice that you may have for these patients that are potentially suffering from GERD.
Absolutely. You should really see someone who knows about not just hiatal hernia, not just TIF, but about all the different anti-reflux options. So if you are planning to, if you are a GERD sufferer and you're really thinking about a surgical intervention to help you, you should seek someone who's trained in TIF and understands the anatomy very well. One of the things that I have to really make sure that we don't talk about this in public sessions, but the surgeons and gastroenterologists who are trained in TIF, they don't just understand their own anatomy. The GI anatomy and surgical anatomy are very different when a gastroenterologist looks inside the stomach as opposed to a surgeon looking from the outside on the stomach. TIF surgeons and gastroenterologists who do TIF procedure, they understand both anatomies. So when you go to someone who has been TIF trained, they just don't understand their own part of the procedure, if you will. They understand globally as to what needs to happen. So you get a much more seasoned surgeon/physician who understands gastroesophageal reflux disease. Not that other surgeons or gastroenterologists don't. It's just that these guys have a lot more training in both anatomies, and they understand this disease. I would say, I venture to say, a lot better than most other gastroenterologists or surgeons.
Yeah, that's a really good point, Dr. Simoni. Thank you for sharing that.
Absolutely. And one last thing, I mean, You mentioned it. I think if you live in an area that's not close to me, please go on GERDhelp.com, and you can just put in your zip code and you can find surgeons or gastroenterologists that are close to you as well.
Yeah, fantastic. Well, thank you so much, Dr. Simoni, again, for being here with us this evening. We have a special edition with you coming up in April for esophageal cancer awareness. So if you want to see Dr. Simoni again, we're going to have a fun little session in April. But again, thank you so much, Dr. Simoni, for being here this evening. We always appreciate having you here. Yeah, and for all of those that are watching, thank you for joining us this evening. We do have another TIF Talk tomorrow, and we usually have them every Tuesday. Sometimes we have them twice a week. We do have one tomorrow. If you want to tune in tomorrow, I believe it's at 5 o'clock Eastern time. So we'll be on the other side of the coast tomorrow. Yeah, but thank you again. Everybody have a fantastic evening. Dr. Simoni, thank you.
Thank you, everyone.
You're welcome. Thank you. Stay safe, everyone. Have a good night.
Stay safe. Yes, thank you. Take care.